One more. All right, welcome to Dental Webinar Series today. We are so glad to have Dr. Beatrice Leung back from Toronto, Canada. She's been a wonderful guest, and I was just sharing her last week we had an opportunity to save ourselves in one case by watching the video. We actually watched the full length of the video before the patient came. So the material you are getting today is really awesome stuff. And Dr. Beatrice Leung, please take it away.
Okay, thank you so much for having me again, and welcome everyone. So if you were here last week, you know that I spent a good 2 hours talking about some materials and implants, particularly planning consideration for dental implants, and also spent quite a bit of time focusing on the delivery challenge, the insertion phase that I see some of my colleagues and students struggling. So I really spent a lot of time talking about that. And what I didn't get to do was talking about the specific topic on single anterior implant. And so, and Uvo said that, you know, I'll come back today to talk about that. And so that's what we're doing. Okay. Today, I really just want to focus on this specific scenario of a single missing tooth. Okay, so something like that. A young patient who may have lost a tooth in the area. It's very common through a bike accident, trauma, whatever. And the rest of the teeth are pretty unrestored, and you have a young patient who needs to be planned for replacement. And now this particular situation, the patient already lost a tooth. This patient already came to me with a tooth loss, but there are situations where people will come to you and the tooth is not completely lost, and you're thinking of an implant. And so many questions will come up from the patient end. As a dentist, I hope that I will guide my colleagues and dental students in the right path. And we talk about this roadmap that I came up with to guide the dental students and the dentists into identify key areas that you need to consider when you start planning anything that involves dental implants. So last time I talked about this roadmap quite a bit. And when you do get to actually end up planning and the implant has been placed, I also talk about the roadmap that you need to walk on, the things that you have to consider in terms of executing the implant related treatment. I didn't get to actually zoom in a lot of these items last time, but I did talk very specifically about the delivery sequence of a single tooth implant crown. Okay. And so for a single tooth implant in the anterior area, they do still follow the same pathway, okay, in terms of the planning and the treatment, okay. What is more critical though, because this is in the front area, everyone wants to know whether they can get it done like yesterday, because no one, as far as in North American standards, no one wants to walk without a front tooth, okay. So there is a particular protocol that has been around that I'm going to talk about. And so this is the book that is written by Dennis Tarnow and Stephen Chu, which are two very prominent specialists in New York. And most of my material is really based on this book because I really love this book. It's scientifically based, it's not overly complicated, but it really focuses on the single tooth implant scenario. When can you consider an immediate implant protocol? an immediate implant protocol where you can extract the tooth, place the implant, and make the temporary implant crown immediately. So I'm really just talking about this particular protocol. When can we consider it? Why do we do it? And really the meat of the presentation is how do we do it? Okay, so that's really what I wanted to focus on today. Now, why do we do it? It's really not that difficult to figure it out. If you look at the immediate implant protocol, it means that the actual appointment is considerably reduced. You can do the extraction, the implant placement, the grafting, and the temporary implant crown, or maybe a custom healing abutment, all on the same appointment. And you let it heal for a period of several weeks, 12 to 24 weeks. And then literally the patient comes back with a healed site, and the site is ready for you to take the impression. And then if everything goes well, your limiting time is when the lab can deliver your implant crown. So you can see if everything goes smoothly, you're looking at about a 3-appointment procedure. Whereas traditionally, when we start doing implant, everything was delayed and staged and things like that. And so when we needed to do, and before this implant immediate protocol came being available and scientifically based, we were extracting the tooth, letting it heal for about anywhere from 6 weeks to 3 months. And then we evaluate if this area has healed adequately. If it doesn't have enough bone, you need ridge augmentation. If the ridge has resulted in some bone loss, and then you might need to build up the bone. And after the bone is built up, you might need another several months for it to heal. And once it's healed, if you have the bone, then you can place the implant. And traditionally, we were placing it into 2 stages. So we would embed the implant first, and at stage 1, and then several months later, we would come back and uncover the implant at stage 2. We would traditionally put in stock healing abutment. So the tissue is not really conditioned to look like a tooth. And so for an anterior area, we would go the extra mile to condition the tissue properly and let the tissue heal properly before we can take the impression. And once we take the impression, then it will be very much like the final delivery appointment, which is whatever the lab can deliver. Okay, so you can imagine when you are dealing with the traditional protocol, all of a sudden you have many appointments and many waiting period for the patient to be without a tooth. Okay, so time-wise, with the immediate protocol, it saves a lot of time from your end. If you're running a business, you know what that means. You're saving time, you're saving costs, but at the same time, you're helping the patient to restore the aesthetic immediately on the same day. If you're told that this tooth is going to come out and you're going to have a tooth on the same day, as a patient, they're going to love you, right? And so it's a great protocol if it's indicated for the right patient, because you help restore the aesthetic. Even if it's a temporary solution, it means a lot for the patient to not be needing to walk without a tooth for several months, or even to have to wear a flipper or to wear an Essex appliance. Okay, patient will accept this treatment a lot better. If you have kind of like a borderline tooth, patient is not in pain, and we've all seen it, and you tell them that this tooth needs to be removed, they might delay treatment. They might not want to have the implant because they'll be told that you'll be months without the tooth, right? And so if you can implement the immediate implant protocol, you just get better patient acceptance. Okay. the other reason why we want to consider is actually a biological reason, and it's a relatively new concept in the last decade, where there is a biological reason why we actually want, if you are going to extract a tooth, place an implant, and do make a temporary restoration immediately to protect the soft and hard tissue. So we call this the dual zone therapeutic concept, which I have referenced the article if you want to read about it. Basically, if you look at the implant that is placed immediately in the extraction socket, there are two areas. There's a soft tissue zone and the bony zone. We wanted to preserve everything, right? And that is the whole concept of, trying to do this immediate placement, is to preserve both the bone and the soft tissue. Okay. What we have found is, if you do place an implant, if it's indicated, it's in the right indication, if you place the implant in the right position, you automatically may have space there. And biologically speaking, you wanted to fill this gap with bone grafting material, not necessarily just for the bone. Specifically in this article, they tell you to fill the bone grafting right to the soft tissue because it helps preserve the soft tissue contour. Okay. In some cases, as we know, if you study bone grafting enough, if you have the buccal plate, sometimes by putting bone grafting material doesn't necessarily help with the preservation of the bone because you have enough bone to begin with. But what this dual zone technique helps is to preserve the soft tissue, which is critical when you're looking at the anterior area for soft tissue aesthetics. And in order to make this work, you don't want this grafting material to be exposed. You want to seal it. And the way you seal it is either by making a temporary implant crown or a custom healing abutment to cover this entire area so that the soft tissue and the hard tissue will heal properly. Okay, so this is just showing you, once you put the temporary material, the temporary crown, whether it's a temporary crown or healing, custom healing abutment, when you remove it after several weeks of healing, you should get a nice flared soft tissue that resembles the original contour of the extraction site, except it's healed. Okay, so that's the biological reason why now everyone is talking about custom healing abutment or making a temporary implant crown on the day of implant placement. Before we talk about extraction, letting it heal, now we're pushing the limit. Well, maybe we can place the implant immediately. If the implant is placed and it's stable, you should consider planning to make a temporary implant crown to seal this area to preserve the soft tissue contour. Okay, so that's the biological reason why you have this implant immediate protocol. There's patient better acceptance. There's a biological reason. It saves time and you help patient restore the aesthetics immediately. Okay. So just to show you a case, this is a case that my former associate, Dr. Jonathan Wang did, and he graciously lent me the picture so I can show you. So this is a case that he did. You can see that this tooth is broken down and there's not much ferrule. And so what he did was he extracted the tooth on the same day. He placed the implant. And you can see he placing the implant and grafting the area. He ended up using the tooth to make the temporary crown. So this is the extracted tooth where he connected to the temporary implant, the temporary abutment, and connected to it so that he'll fill the rest of it with composite resin, such that on the day of delivery, on the day of implant placement, he's able to put this back to that implant. He will have to make sure this implant crown is out of occlusion, so it's not going to look very pretty, because in order to make sure there's no pressure on this implant crown, he needs to alleviate occlusion. So it might mean shortening a little bit, not very little time. There's no proximal contact. And so once you let it heal, you can see he has a beautiful soft tissue after healing, which he can use it to make the permanent implant crown. So we're going to talk a little bit more about, I just want to show you what this whole immediate implant protocol means. Why are we doing it? It's obvious, it restores aesthetics immediately. There's a biological reason for bone grafting and soft tissue preservation. And also, patient really loves this option because patients will be told that you'll likely walk out with a tooth in the mouth and you wouldn't be toothless for several months to come, which is what we had to tell patients before. Okay, now when do we do it? It's very critical. Now, once you see this protocol, it's easy to be excited about it and to consider doing it for everyone, but it's not for everyone. Okay, you have to know when is the right indication. And if you do it in the wrong patient, the result can be disastrous because you might actually go backward and finding yourself doing all the stage treatment because it was the wrong treatment to begin with, and you end up spending more time, then you have to manage the patient's expectation. So it's not for everyone. So it's important for you to know which ones to do and which ones not to do, okay? So again, when do we do it? Just like planning any implant restoration, make sure you look at all these factors. How much space do you have? Do you have the hard and soft tissue to support it? What's the aesthetic like for the other teeth? Is really implant the true treatment indicated for this patient? What's the functional aspect like? And what are some of the patient factors like? Okay, we talked about in the last visit where we talk about there's a thought process that I like to have and I like to teach my students to have, because really after looking at all these factors, sometimes you don't always have the answer. You might have to go through all further consultation, more patient discussion before you arrive with an actual plan. An actual plan to me is 4 stages: the pre-surgical plan, the surgical plan, the prosthetic plan, and the maintenance plan. Okay, now in this case, if you are looking at specifically an implant where you might be considering an immediate protocol, let's look at what are some of the hard and soft tissue key information you need to look at. Okay, in order to make this work, you have to be able to meet 3 criteria. If you are going to extract the teeth, you must be able to place the implant with primary stability. Okay, so this is definitely not a protocol for new dentists, dentists just starting to place implants, because it takes a while before you can really understand how to get primary stability and understand how to manipulate the bone, how to prep the site, and so it's and how to engage the bone to get primary stability. You also have to make sure you can place the implant in the most correct prosthetically driven 3-dimensional position. Okay, so you have to be able to place the implant in the right way. That means you have to have the right bone to support it. Okay, and even if you can place the implant and get primary stability, the 3rd criteria is where I find that not all of us will be able to meet, because the local bone defect, you know, it's not based on skills, it's based on the patient's existing bone. It has to be a favorable defect for this immediate approach. And what do you mean by a favorable defect? Okay, so basically, I took this out from the ITI treatment guide. Again, it mirrors very similarly what's the book by Dennis Tarnow and Stephen Chu talked about. You can't do immediate if you don't have a favorable crest width. You cannot do immediate if you cannot place implant in the most ideal prosthetically driven position. You cannot do immediate if you don't have a favorable defect, meaning you need to have a proper buccal bone. Okay, if you have all these then you can consider immediate protocol. Okay, so just a review of my last week's lecture. What is the ideal position, prosthetically driven implant placement? So for simple single tooth fix, this would be the slide that I always like to talk about. I look at the positioning in 3-dimensional planes. Buccolingually, your reference point is the buccal contour of your ideal restored crown. So wherever this buccal contour is, it needs to be at least 1.8 to 2 millimeter lingual to that most outer surface of the implant. So what does that mean? That means your existing tooth should be already be ideal. If it's too tip, too buccal, then you shouldn't use it as your reference point. So if you have a tooth that is ideally positioned already, then you can probably rely on the existing buccal contour to help you plan the implant. So that's buccolingually, okay? Mesiodistally, you look at the adjacent root. You wanted to leave at least 1.5 to 2 millimeter of space between the adjacent root surface to the outer surface of the implant. This is to preserve the dental papilla so that you have enough bone to support the soft tissue here. Okay, now apical coronally, this is where I find that not many people talk about it, but that's very important for gingival aesthetics. Your reference point is your ideal gingival margin, the soft tissue margin, wherever that is. How deep to place the implant, it should be about 3 to 4 millimeter apical to the gingival margin. Okay, and sometimes people use the CUJ as a reference point, but I find that if the patient's gingival margin has some recession, then it may not always be a reliable reference point. So I use the ideal gingival margin as my reference point. Wherever that is, your implant should be about 3 to 4 millimeter apical to that. Okay, so that's just implant positioning. Irrespective of where bone is, you need to know where the ideal implant should be so you can evaluate whether you can do the immediate protocol or not. Okay, so this is just showing you the ideal positioning. It should be 1.8 to 2 millimeter lingual to the ideal contour of the restore restoration. Okay, if the tooth is missing, you might need to do a diagnostic wax up to determine where that is. If the existing tooth is there, you have to ask yourself, do you like where that is? Is it too buccal? Is it too lingual? If it is, then you shouldn't use that as your reference point. You might have to trim that tooth and put it in the ideal tooth before you plan where the positioning of the implant needs to be. Mesiodistally, it should be 1.5 to 2 from the adjacent root. And then occlusogingivally, we look at the gingival margin, which the implant should be at least 3 to 4 millimeter apical to the gingival margin. If you place it too shallow, you're not going to be able to develop the proper emergence profile, and you might risk showing the implant as well. If you place it too deep, you might risk bringing too much bone and recession down, and you might risk making the crown looking too long prosthetically, and you might also risk losing the interdental papilla. Okay, so 3-dimensionally, know what the reference points are, know how to plan your implant 3-dimensionally, how to position it in the most ideal way. Okay, then you look at where the bone is. Okay, now this is just showing you in this, and this is based on the book from Dr. Chu and Dr. Dennis Tarnow. You look at the bone and they say the biggest thing is there a buccal plate? Okay, that is what's going to determine the predictability of the soft tissue and in long term. Okay, so in his book he said, there's type 1, type 2, and type 3. Type 1, you can see there's crestal bone all the way to the CEJ. There's soft tissue all the way down to this, the CEJ. This is the most ideal situation where you want to do the immediate protocol. Type 3 is you don't have the bone nor the soft tissue. Even if you can get immediate placement by having primary stability, you're going to lose soft tissue here. So this is not the case where you should consider immediate protocol because you don't have the biology to support the soft tissue stability. Somewhere in the middle here, they said, if you don't have the bone, but you have the soft tissue and you're able to place the implant and get primary stability, then maybe you can do bone grafting with the need of a membrane. But this calls for a very, it's not for entry-level dentists. So you need to know how to do bone grafting properly. You have to know how to manipulate the membrane. And so even that, I question for new dentists to consider that. This definitely, it makes sense if you can remove the tooth, place an implant, and there's buccal bone, there's soft tissue. This is very predictable. So my recommendation, if you're considering immediate protocol, this is a case where you want to start. You don't do a case like this. This may be for experienced dentists who's been grafting, who's been doing surgery a long time ago. This, you can still do it because you have soft tissue, but you do need to put a membrane to allow the bone to grow. So this, it depends on a lot of scenario to be predictable and successful. Okay, so this is the type of situation where I think, you know, we can consider immediate placement and immediate provisionalization to help support the bone and the soft tissue. Okay, so ideal implant positioning, I already talked about it, but I just thought I'll put it in here again, just so that you can really know it well. It should be 3 to 4 millimeter in the apical coronal position from the soft tissue crest. It should be slightly palatal to the line bisecting the buccal lingual position of the definitive restoration with a single and sagittal angulation. And it should be bisecting the mesial distal space with at least 1.5 millimeter between the implant and adjacent teeth. So basically they have, to me, it's the same thing, but it helps for you to read it from a different language. So it may help you to visualize where the ideal implant placement should be. Okay. If you are going to do the immediate implant protocol, you have to have primary stability. And so most of the time, the strategies that involved is actually making sure you engage a little bit of the apical bone and the palatal bone in order to gain primary stability. Okay, so this is just the same case that I showed before, where the implant was, the tooth was extracted, implant placed, and then they grafted the area, and then Dr. Wong used the extracted tooth to make the temporary implant crown and make sure that it's out of occlusion. And when you do that, you have a healed site that preserve very well the original contour, soft tissue, and the flare, and support the new restoration. Okay, so what I have talked about is just the local factors, the restorative space, the hard and soft tissue consideration. There's also other factors you have to factor in before you consider doing an immediate implant protocol. A lot of it has to do with patient factors. Okay, what kind of patient factors are we considering? Does the site have an existing infection? What type of soft tissue? We talk about gingival phenotype. There's thick and thin. So thin gingival biotype tend to be more likely to have recession. Thick gingival biotype tend to be more resistant to recession. So usually I like to look at a thick gingival biotype. What's the patient's medical status like? Is the patient diabetic, immunocompromised? Is the patient a smoker? And what's the patient's expectation? Okay, so it's easy to be excited about doing this immediate implant protocol. But once you look at the clinical aspect, the biological aspect, to see if the patient is a candidate, on top of it, I wanted to make sure this is the right patient to consider this treatment. Now, I wanted to bring back this little ITI treatment guide, which tells you about risk factors, aesthetic risk factors. So it just kind of help you understand where your patient may fall under the aesthetic risk. This is a low risk, medium, and high risk. Okay, so again, from my roadmap, we talk about patient factors, which really includes the medical status, does the patient smoke, and whether the patient has realistic expectations, right? There's the gingival biotype. You know, if you have patients who have thick biotype, then the aesthetic risk is very low. But if you have a patient who have very high scallop thin biotype, the aesthetic risk is high. Okay, so there are other things that, you know, you should look at: the shape of the teeth, the restorative status of the adjacent teeth, soft tissue anatomy, bone level, all kinds of other things. So I thought it would be useful to put this here so everyone can take a look at it. It's another way of looking at your patient in terms of the aesthetic risk for implant treatment. Okay, so that covers when do we do it. I think it helps to put things in perspective when you're doing clinical exam. We talk about why do we do it, when should we do it, when should we not do it. I hope that, you know, help you plan it. And now I think the meat of the presentation is how do we do it? Okay, how do we do it? I think that's what you will want me to talk about. How do I make a temporary implant crown? So I'm going to follow this sequence. And this sequence is an article that I quoted, also written by Dr. Stephen Chu, because I think it helps you to understand the steps taken for something of this protocol. Okay, so everyone's just think about, oh yeah, just remove the tooth, place the implant, and then make a temporary crown. But just like when you do your crown, when you do your bridge, before you pick up your handpiece, you have to have a plan how to make your temporary, right? So it may be, you may decide to do a chair side, do an impression of the tooth before you prep it, but there are times the tooth is missing or partly gone. So how do you plan so that on the day of the surgery, you know how to make your temporary crown? So in this particular article, Dr. Stephen Chu talked about taking an alginate impression and using that impression to make a shell of acrylic out of the tooth. Okay, so this is something that you can certainly consider doing it. So you just take an impression of the tooth before it's extracted. And what you would do is you use traditional jet or PMMA material where there's liquid monomer and powder polymer. And this is actually a very classic way of doing things. So if you were practicing prosto in the 80s and 90s, this is your basic skill set. You would have a sable brush where you would just dip in the monomer and pick up a bead of the polymer and paint it on the tooth where you want it. So you just wanted to make a shell of the particular tooth that you know you're going to make a temporary crown. Okay, so you just use this brush and dip it into this the monomer and the powder, pick up a bead of powder, go around this wherever the tooth you wanted to make a temporary until you have essentially you're going to make a blob of a tooth. Once it's set, you tease it out and then you core out the inside, or maybe you finish it up so that, you know, here in the article, they suggest you to make a big hole on the occlusal surface or the lingual surface, because that's going to help you make your temporary implant restoration later on. But this is a step that was recommended by Dr. Stephen Chu's article. And I find that a lot of people actually, even in the Toronto setting, not a lot of people know how to use this material anymore, but I show it just for historical reasons so you know where it came from. So Dr. Chu in his article talked about using this to make a shell of a temporary crown to be ready to be used for making the temporary before you extract the tooth. Alternatively, you can use the patient's extracted tooth, like the one that I show you from Dr. Wong's case. You can definitely use the tooth and core it out and connect it to make a temporary crown. Okay, so you guys, my point is, before you start extracting the tooth, you have to have a plan. So just like when you're doing a crown or bridge, you don't want to start filing the tooth and then you realize you didn't have an impression or a shell, or maybe you decide just to do a block 10, which is fine, but you need to have a plan to make make your temporary implant crown. What I usually do is, before I do anything, I just take a sectional impression of the area, and I use bite registration material, which tends to set a lot faster than traditional impression. But it just gives me a mold of the particular tooth that I'm going to make a temporary crown. Okay. If the tooth is missing to begin with, you may have to do a little bit of prep work, where you might have to, take the impression, wax up the tooth, duplicate it, and make sure you have an index, whether it's a vacuum form matrix or a putty index of some sort. Okay, I'm just showing you, these are the prep work that you often have to think about if you are going to make an implant, immediate implant temporary crown. Okay, so let's suppose that you already have a plan, whether it's using the patient's tooth, or you take an alginate and follow Dr. Steven Chu's protocol to do a paint in acrylic resin shell, or you take an sectional impression like I do, or you do a wax up and make sure you have something ready to go, then you can consider extracting the tooth. Okay, the idea is you don't want to start extracting the tooth and not have a plan to make it temporary. Now, extracting the tooth, I'm not going to go in a lot of details, but the idea is you want it to be as atraumatic as possible. You want to preserve the bone. You don't want to luxate the tooth and break your buccal bone. Remember, you want to preserve the buccal bone, right? So certain strategies that people have talked about is you luxate it mesial-distally, never buccal-lingually. You might want to section the root mesial-distally and luxate the root tip out, because you want to preserve the soft tissue and hard tissue contour. Other strategies you might have learned is just use of endophile to retrieve your broken roots, so that you don't have to start digging around the soft and hard tissue. Okay, so basically, one of the key thing is to try to remove the root as atraumatically as possible, so you preserve the bone and soft tissue. Once you removed it, then extra step you need to do is you wanted to clean out the socket, make sure there's no granulation tissue, and check to make sure you have the buccal plate. You want to make sure that you have at least a buccal bone 4 millimeter apical from the ideal free gingival margin. Okay, so obviously once you extract the tooth, you use the correct to, if there's any granulation tissue, remove it so it's sound bone. You might want to just rinse out all the debris inside and use a perio probe to determine where the buccal bone plate is. And you need to make sure, that you have the buccal plate is about 4 millimeter away from the gingival margin. Assuming you like where this gingival margin is, you just want to sound the bone and see where that bony buccal plate is. If it's too deep, then you don't have the buccal plate, and you might decide that you want to stage it, graft it, or you might have to use the membrane to graft some bone in that area. Okay, because if you don't have the bone, your soft tissue is not going to support it, and you might have a non-ideal aesthetic outcome of the case. Okay, you may have the bone to place it, you may have the primary stability, but in order to have the stability of the soft and hard tissue, you need the buccal plate at 4 millimeter apical to the gingival margin. Okay. So once you've determined you have the buccal plate, you can do the implant placement. Obviously, you're going to place the implant in the most ideal prosthetically driven position. And so a couple of strategies that I know of is you need to engage and go beyond the root apex in order to get primary stability. That's usually the strategy. You want to go longer implant to have apical engagement. Usually I also want to make sure I engage the palatal bone. That's how I learned. Always feel the palatal bone. And if you're going to consider immediate, you should plan an implant that is long enough to engage the apical aspect of this bone. You want to make sure you're placing it in still three-dimensionally restorable way. So make sure you know where the positions are. And it's easy to get primary stability, but then I've seen so many implants where they're placed, but they're not prosthetically driven. They've gone too buccal because they went into engage this buccal bone, this palatal bone, so it's going to buccal. So while you have an implant that has primary stability, prosthetically, it's not ideal. Also, I know that if you use a denser bone drill, that's another way to get the bone to be dense, and so you get primary stability. So like again, if you remember from my last presentation, I also place implants, although I don't usually teach about placing implants, but I just want to share some strategies I know of when it comes to immediate implant placement so that you can get primary stability. Okay, so once you position it and you get primary stability, you're happy with the position, that's really when you can start making the implant crown. Okay, so the components you need to get are what we call usually temporary abutments. If it's a single unit, you need to make sure that it's a hex abutment, so it has anti-rotational element to it. I talk a lot about that in my other course. Understanding these components sometimes takes some time to digest. So, but one of the things that you will see that a lot of these temporary abutments, some of them are tooth color, some of them are titanium, and they're not all made equal. Okay, my experience is that usually once I order it, I look at the surface design. You can see these ones have a lot more mechanical retention, a lot more grooves. And because your temporary material is going to, most of the time, adhere to this by mechanical retention, especially titanium, okay? So when I look at these titanium implant temporary abutments, I thought these surfaces are not rough enough. And the first time I used this, I was right. The acrylic actually debonded on me. So sometimes I intentionally create more slots and holes inside these abutments so that the material can lock in a little bit better. Sometimes I don't need to do that. They work really well. So what I'm saying is every brand, every implant company will come up with some temporary abutments. Some of them are tooth color. Some of them are titanium based. But I always make an effort sometimes just to look at the surface design, because most of the temporary are locked into by mechanical retention. So if I don't like how they look very smooth to me. Sometimes before I even start, I roughen quite a bit because it gets really bloody and contaminated once in the mouth. So I want to do this once and for all, and I don't want to go back and add and adjust. So one of the things I've learned is that, the first one I made many years ago, it debonded on me the next day. So I learned that just because it was made as a temporary doesn't mean it has the right surface characterization for mechanical retention. So oftentimes I will go back and just drill into these surfaces and make holes to create more mechanical slots and holes. Okay, so these are just samples that I'm showing you. You can use a tooth color temporary abutment. I find that most of the time I just use the metal ones. I can most of the time find that I can hide enough of it. It's not an issue, but obviously with a tooth color one, you don't have to worry about the color showing through as much. But just showing you these two are side by side. This is a Strawman temporary abutment, and this is a Horizon temporary abutment. You can see the surface structure are different. And so I find that the one with Horizon, even you see a lot of surface texture, it's too shallow. It's too shallow that I often find that I have to go in and roughen the surface because the acrylic is not going to adhere to that very well. Okay, so one of the ways is you use the patient's tooth, you have to core out the tooth so that you can position it over the implant. Okay, so in this case, you kind of have to put the implant, the temporary implant abutment on the implant and core out the inside of the tooth such that you can position it where it looks reasonably acceptable to you and the patient. And basically, you just add some composite resin to this so that it adheres to it. On the inside surface of the tooth, you might have to etch and put some prime and bond so that it adheres to it. Okay. The idea is you just want to position it in the mouth so it looks reasonably well. You don't have to do the rest of it outside the mouth, inside the mouth. So once you have it secure, then you can remove it. And then outside the mouth, you can finish it off, fill in all the voids and create a nice smooth surface. Now you can look at this, you can see this nice smooth surface. The idea is to create this emergence profile that's going to support the soft tissue. I'm going to talk a little bit about how this should be. Is it, other than it being smooth, should it be convex, concave? So I'm going to talk a little bit about that because there are different opinions, and I'll share with you what I think it should be. One of the key things I've seen is there is a finish margin on the temporary abutment. You have to know how to read that. So you want to add enough acrylic or composite resin, but you have to trim it back so it's nice and smooth. You don't want to have extra one kind of going beyond that. If you do, you might not be able to see this crown, and also might cause soft tissue and bony tissue irritation because you will have too much resin that is interfering with this abutment implant interface. Okay, now this is not a single tooth implant, but this is the case that I actually documented to show you the steps what I'm doing. This is not immediate, just so that you know. The implant was already placed, but I'm going back to making a temporary. So one of the things, when you put that into the mouth, you will find that these prefabricated temporary abutments are way too long, way too long. It interferes with the occlusion. You cannot see the matrix properly. So one of the things that you have to do is to reduce the abutment until the matrix can seat properly and it doesn't interfere occlusion. Okay. Now, when you have to reduce it, you can either reduce it intraorally with lots of irrigation or extraorally. Okay. I find that if I'm not doing immediate placement, I find that it's faster for me to reduce it intraorally. But if you've never done it, it may scare you because it can create a lot of sparks, okay? And so that's why you need lots of irrigation to keep things cool. And if you want, if it makes you more comfortable, you might just want to mark it with a Sharpie marker where it needs to be reduced, remove it, and then reduce it extraorally and put it back, make sure you have in and out. I find the in and out slows me down significantly. So you'll find that I usually just do it intraorally. But when you do it intraorally, it does make it a little bit messy because you can see a lot of the metal bits and pieces that can get stuck in the area. So I don't recommend doing it if you are doing it immediate because you need the socket to be not have all these pieces here. Like I said, this is not an immediate case, but I just happen to be making a temporary crown, and so I can document the steps. Okay, so if you have to reduce it extraorally, it makes you comfortable, then do it. Okay, if you do it intraorally, just beware there's sparks and water, and it can be quite messy. Okay, when you have when you're ready to make the temporary, once you've reduced it, there's a couple of key things I wanted to tell you to do. One thing is that when I look at the adjacent teeth, if teeth are very bulbous, there's a black triangles undercut here. I usually like to block out this area so the acrylic doesn't get stuck. And the easiest way to do it is just put a cotton pallet there. So you can see that I put a cotton pallet here so that my acrylic doesn't go into this space, because I've done it too many times without it, it gets stuck. And it's okay, I can always retrieve it. But it just, if you've never done it, I think some people will get scared because they cannot retrieve it. So my recommendation is put a cotton pallet underneath the adjacent teeth so things don't get stuck. The other thing you have to make sure you do is you cover the access hole with cotton pallet. You don't want the acrylic flowing right into it because you need to be able to access the screw to remove it. Okay, so once you reduce the temporary abutment adequately, you put the cotton pallet to seal the access hole. You put cotton pallet in areas where you think it's going to get blocked out. And you want to make sure that the index is seated properly. Okay, at this point, I want to rinse out all the debris here, make sure that this surface is not moist. This surface is dry, so it can adhere to the surface of the abutment. And so now, you know, once you get the implant abutment ready, that's where whatever you did, whatever matrix you had done, or the shell of acrylic, then you can load it up with acrylic, okay, or jet or PMMA, whatever you want to do, just like making a temporary crown, a temporary bridge, the same goes. So you want to position it back in the mouth. Okay, so you load it with the acrylic, you position it back in the mouth in the same way. Now, this is where I feel that people don't reduce their abutment enough. They can't see, and so they position it incorrectly. So this is where errors can happen, okay? So that's why every step is so critical. You wanna make sure you reduce the abutment adequately. If you have a matrix that is clear, then you can see it where it's fully seated. If you have a shell, then you can also see it. So depending on which method of provisionalization you choose, it's built in some possible errors that you have to encounter. But the idea is you want just to have some acrylic to be connected to the abutment. Okay, so this is just an example what I did of that same case. Okay, you can see that I just have enough acrylic to be connected to the temporary abutment. You can see that it picked up the cotton pallet. You can see that this is properly the proximal contact because I have the cotton pallet. It didn't get stuck in there. I have it connected, which I'm going to separate as the two individual temporary implant crown. This implant was more buccally placed, so I have to go in to screw, to drill through the acrylic to identify the access hole to remove the cotton pallet in order to access the screws, so I can remove this altogether. Okay, so this is also where sometimes I find that people get stuck because they have too much acrylic or they don't know where to drill through to get the access. So some of the strategies you wanted to make sure you put enough cotton pallet or maybe even taller just so that it comes through so you can see it. It's only a thin of acrylic, a ring of acrylic that you need to drill through to get through the cotton pallet and the screws. So it doesn't look very pretty right now, but that's where, you know, the work starts outside the mouth. Once it's outside the mouth, the first thing you need to do is connect that temporary with I usually have an analog ready because it helps me hold this temporary crown better. And basically I connect this abutment to the analog to help me hold this whole piece. Then I just add flowable resin all the way to this finish line. And I start shaping this to make it look like a tooth. So you can see this is a finished product. This patient has worn this for about several months already, and you can see that the stain, everything, but you can literally see where I added and where it was. And so that's how I make a temporary implant crown. This is the other unit I separated. So this is a Straumann implant where, you know, this is the cotton pallet that got picked up. And because it picked up that cotton pallet, it didn't get stuck. If I didn't put a cotton pallet, this temporary might get stuck and you might have to drill through the interproximal in order to get it removed. So sometimes that's not very fun to do. But basically, I just connect it with an analog and then I flow resin, composite resin, and just shape it so it's nice and smooth. Make sure it goes to the finish line, not beyond, and then it's nice and smooth. Okay, so when you put this back on, a couple of things I wanted to mention is the idea of doing that is to allow you to have soft tissue conditioning. So like I said, this is not a very beautiful case, but it just helped me show you the steps. And so this patient has 2 implants. This is a Straumann implant. This is a Far Horizon implant. And I just wanted to show you, I want to make this temporary crown so I can develop the soft tissue contour as ideally as possible. And so sometimes even if I do it, I don't always get ideal soft tissue, but it's a method to give you a soft tissue seal and also to start developing the contour that you want to develop the contour for. So a couple of things that I want to talk about is that some people talk about this gingival emergence profile should be concave rather than convex. Okay, most of the people talk about that this should be concave because it allows more soft tissue to fill into. So this is concave. This is convex. You can see the blanching of the tissue. Okay, so basically, this is the healed site. You can see that the soft tissue here has filled into here a lot better. Have I made it too convex, I might not have the room for the soft tissue to fill in. Okay, you can see even between these 2 implants, I didn't get complete soft tissue fill. I won't because I am knowing the biology, but at least I'm trying to develop a little bit more of a natural soft tissue contour. Okay, the idea of making the temporary implant crown, even if it's not immediate place, it allows you to develop the soft tissue shape to make your permanent restoration a little bit better. Okay, so once you have this patient wearing the temporary crown properly, when you remove it, you get this soft tissue flare. What it does, it allows you, so this is an implant crown that is for this site. It allows you to make what we call a customized impression coping. So this is just an open tray impression coping, but what I did is I customized it so the gingival contour helps to support this soft tissue. So when I take the impression, it's recorded. Okay, that's another reason why for my anterior implant case, even if I'm not doing immediate protocol, routinely I make a temporary implant crown to condition the soft tissue first before I take impression, because it allows me to develop this proper soft tissue contour. It also allows me to talk more objectively with the patient, what's achievable, what's not. And so it's a step towards starting to manage the patient's expectation so they know what's feasible and what's not. And at the time of the impression, it allows me to customize the impression coping. So I record that information for the lab. So the lab will produce something that will resemble this contour rather than the contour that is arbitrarily built in, whether it may be too fat or too narrow. Okay. At the end of the day, whether it's an implant immediate protocol or at second stage, you have a temporary implant crown. For a single unit, it's usually a hex abutment. So it has built-in anti-rotational element. It needs to be smooth. Okay. Usually you have no occlusion on this temporary, eccentric or excursive. Okay. Some people will go as far as saying you shouldn't have any proximal contact, but to me, that seems to encourage food impaction, and that can affect soft tissue health. So I tend to have a light proximal contact because I want to minimize food impaction. Okay. At the end of this whole exercise, your provisional restoration should have the tooth in the form that it replaced the tooth. The emergence profile should be supportive of the soft tissue. So it looks like it's supporting the soft tissue and not making it too bulbous or too under contour. The tooth must be in infraocclusion, so it should not be in direct occlusal contact with the adjacent teeth or the opposing occlusion. And that's very important for immediate protocol. Okay. So once you've placed, you've made your temporary implant crown, you're going to, you have to do that first. Okay. And then they talk about placing the bone grafting material into the space so you can put the implant crown back on there. Okay. Now I want to talk a little bit about the integral surface. Like I said, you will find that a lot of people say that it needs to be concave, but I find that in some cases I need to make it convex because it all depends on the position of the implant. And sometimes if the implant is not placed in the most ideal way, for whatever reason, this is where the emergence profile of my temporary implant crown needs to be contoured to support the soft tissue to provide them optimal aesthetics. Okay, basically, two rules I want you to remember. If you make it more concave, like how I am showing it here, which is what most people say, most of your emergence profiles should be concave so you have more soft tissue to support the area. And this is also, that's going to affect where the gingival margin needs to be. So if you do develop it more concave, the gingival margin will tend to come down occlusally. If you make it too convex, you tend to push the soft tissue up and above, and you may push it too gingivally, too apically, which may be aesthetically not ideal. So I want to share this detail with you guys because when you, even if you don't make the temporary crown, if you get the lab to make it, they might shape it in a way that might not support the soft tissue because they don't really see the soft tissue response like you do. So this is a case I just want to share with you. This patient, as you can see, in the 2-1 has external root resorption. This was initially planned for extraction, immediate placement, and immediate provisionalization. But we didn't end up doing immediate provisionalization because the periodontist felt that it was a very tough extraction and maybe it doesn't have the ideal primary stability. So we ended up just letting this heal, and I ended up just giving the patient an Essex for the time being. However, when the implant has healed properly and I got the go-ahead from the periodontist to make the definitive restoration, because it's an anterior case, I don't jump to the direct final restoration. I actually make a temporary implant crown first. So in this case, I actually digitally scan the case. So you can see this is the scan body. I scan it and I had the lab make it. I just didn't have the time to make it chair side. I thought the lab can make it nice and pretty. And so this is the temporary implant abutment. It's going to show up radiolucent because this is a temporary material. But you can see that there's blanching, and at the time when I inserted it, you can see that I didn't like the gingival margin that kind of pushed it too high. So it's too convex the way the lab made it. Okay, so I chair side reduced the convexity of the contour of the emergence profile to make it a little bit more concave. And so this is how the tissue looked. Okay, so I brought it down, you can see it, but not completely down. But you can see by just manipulating the gingival emergence profile of the temporary crown, you actually can alter how the tissue will look. So that's why I actually believe that in some ways, you know, whether it should be concave or convex, it depends on the position of the implant. And sometimes you have to understand how this is shaped can influence the soft tissue contour. Okay, so I'm just showing you a couple of examples of the temporary implant crown I did for the patient. These are all chair side, didn't have the lab to make it. And so idea is to provide the most natural gingival shape of the implant for the implant restoration. Okay, so This is an implant temporary crown. This is a temporary implant crown. This is a temporary implant crown. And when you remove that temporary implant crown, you can see the soft tissue flare. Some are much more flare than others, depending on the size of the tooth, the contour of the tooth. But what it does now allow me to do is it allows me to customize the impression coping. Okay, it allows me to customize the impression coping so the lab has the more knowledge about the soft tissue contour that it needs to be shaped for your final definitive restoration. Okay, so for these cases, these are the customized impression coping. Basically, it's just impression coping where there's a ring of acrylic kind of wrapped around the impression coping to support the soft tissue. So when you take the impression, it registers the shape of the soft tissue you wanted the lab to build to. Okay, so when you take the impression, when you remove it, you can see the gingival contour of these impression because it captured that information, and the model would have that defined shape so the lab can make the temporary or the definitive implant restoration with the more ideal emergence profile. Okay. So these are just some of the anterior cases, you know, that I did. So this is the implant. This is an implant. This, I ended up doing two crowns. This is a natural tooth, and this is an implant crown. And so this is just one implant. Okay. So I'm going to just finish this presentation by talking about the steps for customizing the impression coping. Okay. So basically, the whole point of making a temporary implant crown, first, if you're doing immediate protocol, is it offers you an opportunity to restore aesthetics and also to do a soft tissue seal for the bone grafting. Even if you're not doing immediate implant protocol, my anterior implant crowns always have a temporary because it allows me to shape the soft tissue the way I want it. It allows the soft tissue to heal around it and allows me to talk to the patient what's feasible, what's not feasible. And once the soft tissue heals properly, then I can make an impression by customizing my impression coping. Okay, so these are the steps that I take. And so I'm going to go step by step how to do that. Okay, now, before I go any further, my original presentation talked about all these methods. You can go direct or you can go indirect. Okay, my preferred way is going indirect open tray technique. That's what I do, and that's what I'm going to show you. But that's not the only way to do it. And if you look at implant companies' catalog, they will show you some of the direct methods. In another presentation, I talk about their pros and cons, but I don't have the time today to talk about it. So I skip all that. So basically, what I'm doing is I'm just talking about the indirect open tray technique. Okay. So let's suppose then this is a patient with an implant with a temporary, okay? You can see that I lost some soft tissue, but I still made it doesn't have the ideal interdental papilla. There was some soft tissue trauma to that area. I had to do a lot of bone grafting in the area, but anyways, I was able to make a temporary implant crown for him and let the soft tissue heal. So this is where, you have a patient with temporary crown already. And the first step is to remove that temporary implant crown. You remove that temporary implant crown and connect it with an analog. Okay, so what essentially you're trying to do is you wanted to capture the gingival emergence profile of the temporary and capture that. So with this temporary crown with an analog, usually I will make a mold of this area. So to do this quickly, I usually have a medicine cup ready, and I usually use by registration material to make the mold because it sets fast And so this is what I would do. So you can see that I just use a medicine cup. I inject a mountain of bi-registration material. This is just blue mousse. And before it sets, I embed the whole thing, the temporary crown and the analog, inside to this mountain of registration material before it sets. I want to make sure that the registration material captures the gingival emergence profile of my implant crown. It doesn't have to embed this whole crown entirely. In fact, if you do too much of it, it's harder to remove it. But I just want to capture the gingival emergence profile of this implant crown with the analog connected to it. Once it's set, you will remove this implant crown. Okay, so this is another case similarly. You have the patient with a temporary, the soft tissue has healed, the temporary crown is now connected to the analog. You inject here, they're just using heavy body impression material. I use bi-registration material because it sets faster. Before it sets, you just embed the whole bottom portion, including the analog and the bottom half of the temporary implant crown. You let it set. Once it's set, you remove the temporary crown. What you're going to see is you're going to see the implant analog embedded inside to this impression material. And also you have captured the emergence profile of the temporary crown. Okay. So remove the implant crown from the analog. Okay. And then you see that you have the analog inside there. Now you just take an open tray impression coping connected to this analog. What you will see is you got a space here. That emergence profile that you have created, there's a space now. So this space is what you're going to fill this up with either flowable resin or self-curing resin. Okay. So I usually use flowable resin, but you can also use GC resin that sets fairly quickly. Once it's completely set, then you can remove that and trim any excess flash. Okay, so this is just showing you the case that I did. I put an impression coping there, and the space that was left between the temporary crown, I fill it up with flowable resin. Once I fill it up with flowable resin, remove it and make sure it's smooth. I want to make sure that if I put it into the implant, it's not touching on the adjacent teeth. So if you do too much of it, you have to trim this back. And so that's how you make a customized impression coping that follows the contour of your temporary implant crown. Okay, so make an impression of the implant crown with the analog, remove that, put the impression coping, fill this up with flowable resin, and then remove any flash, any sharp edges. Then you can put this on to the implant, take an x-ray, and that's how you take an impression. When you take an impression, when you remove it, basically you capture the gingival emergence profile of the implant where you have conditioned it using your temporary implant crown. Okay, so this is just showing you a couple of different cases I've done. This is, you know, the case where I had the temporary implant crown, then I customized the impression coping. This is now depending on what material you use. When you take the x-ray, sometimes it will show up, sometimes it doesn't show up. If you use GC resin, it's going to show up radiolucent. Here I probably use a radial opaque form of flowable resin, so you can see the little flare on the impression coping. Okay, and when you take that out, you can see the gingival emergence profile. Then so when the lab pours it up, it captures that information accurately. Okay, so this is another case with the impression coping that's customized and what it would look like on the integral surface after the impression has been taken. This is just showing you when you use GC resin, when you take an impression, it's going to show up radiolucent. Doesn't mean you don't have it. It's just beware of that because it's GC resin, it's radiolucent on the X-ray. Okay. So this is just showing you the implant that's placed. That this was removed, it was bone grafted, it was placed, and then I think I added a tooth to it at the time. I didn't provisionalize at the same time, but when I did provisionalize it, okay, you can see the composite resin to provide better soft tissue contour. And when I take the final impression, it's not going to show up on the radiograph because I use GC resin, which is radiolucent, and then the final restoration of the implant and the natural tooth. Okay. So just be aware the radiographic appearance of your customized impression coping depends on the material you use. For GC resin, it's going to show up radiolucent. For if you use composite resin, then it might show up as radio opaque. Okay. So this is the temporary implant crown that I made for this patient. It's showing up as radio opaque. The actual customized impression coping, I don't think I have a picture of it, but it just shows you, you can see the ring of composite resin around my impression coping. Okay. So these are some of the anterior implant cases I did. For someone who has that, this I didn't plan it, but the patient came already with the implant placed. So I always make a temporary implant crown. As you can see, the color isn't perfect. And then once I make the temporary implant crown, I customize it at the time of the impression. So then the lab can make the soft tissue contour as best as possible to match the patient's existing gum contour. Okay, so again, you make the impression with the temporary implant crown. You remove it and put an impression coping and just flow some resin around it or GC resin, trim the excess, make sure it doesn't touch the adjacent teeth. And then you take an impression. And that's how you do customized impression coping using the patient's temporary crown. Okay, the key is to make sure that you position it adequately so you can retrieve the screw. One thing I wanted to mention is you can see that a lot of my cases I use custom tray, and custom tray costs more money and time. I see some of my colleagues and students want to just use stock tray. Stock trays, you might get away with it, but there are times when I try to do that, I'll share with you the challenges. With a custom tray, it customized to the patient's unique arch shape. It allows you to provide an even space of material for the impression material. It also customizes the opening so it's easy for you to access the screw. Because I like to do open tray, I find that it's more accurate in my hands. I tend to use a custom tray. But the disadvantage of that it adds to your lab cost. It takes time to fabricate. But the problem I find when you're using stock tray is sometimes the stock tray is shaped in such a way that the screw is not long enough for me to retrieve it, or the stock tray may be impinging on the vestibule, so I cannot position it the most ideal way, leaving that I have too little material in some areas. I might not be able to retrieve the screw easily. Okay, so this is a case that I thought, oh, this patient has a fairly standard shape of the arch. I could get away with just using stock tray. I create an opening, and I had when I took it, it took me by surprise because the screw was not long enough. So I have to, at the time when I take the impression, I have to wipe enough material so I can see this access hole. So what does it mean? It means I might have too thin of material, so it might not be as accurate. And the other thing is I was trying to push it down more so I can get more of this screw exposed, and I was hitting the patient's lingual tori, and so it was hurting her. So in this case, even though I thought it was a standard case, a single tooth implant, I was lazy. I didn't prepare a custom tray, but these are the challenges I find myself facing whenever I use a stock tray. So when you're taking impression with implant where you're doing an indirect open tray, it's critical that you need to position it ideally so you can retrieve the screw. And so by doing a custom tray, I find that it eliminates all these problems. Okay. So that's all. I think I've covered a lot of things today on single anterior missing tooth, specifically talking about the immediate implant protocol. And if you are going to plan on making temporary implant crown for the aesthetic zone, what to consider and what challenges you may face and why we're doing it all together. The key thing is if it's part of your immediate protocol, it offers a soft tissue seal for the bone grafting material. So there is a biological reason. It restores the aesthetics. It's just better patient acceptance. But if you end up staging your anterior implant, just you didn't do implant placement immediately, you went back to bone grafting, whatever. For me, when the case is ready for restoration, I still make a temporary implant crown for the patient first, whether chair side or you took an impression, because it allows me to condition the soft tissue, allows me to customize the impression coping, and allows me to manage the patient's expectation in terms of the contour, what's possible, where the gingival margin is there a black triangle that you should anticipate, and things like that. I find that for a single anterior missing tooth, because it's very aesthetically oriented driven, patient does have high expectation. And by implementing these steps, I find that I have better outcome in terms of the patient's expectation and also the soft tissue contour. Okay, so why do we do the immediate implant protocol? It restores the aesthetics. There's a biological reason for bone grafting. It preserves the soft tissue, and also you get better patient acceptance, but it's not for everyone. Okay. You can only consider that if you can have primary stability, if the implant can be positioned in the most correct prosthetically driven position, and that you have buccal plate to work with. Okay, you have to have an ideal local bone defect that shows favorable morphology for you to consider that. Okay, and keep in mind of the patient factors. Not everyone is suited for that. If they have thin gingiva, they are high risk. Patients with existing infection, the heavy smoker, those are cases I would be a little bit cautious, or I have to manage the expectation that I might still not get an ideal outcome, even if everything had gone smoothly from the surgical aspect. The patient's factor, the healing potential, sometimes can compromise the outcome as well. Okay, so this was supposed to be the summary of my last lecture. We talked about implant treatment planning, consideration, the roadmap you need to consider very quickly last week. We also talked about the treatment execution phase, specifically the delivering consideration for single tooth implant. And today I really just talk about the single anterior solution, talking specifically about how to make the temporary implant crown, the why, and the how. And I hope that you found this presentation useful. Okay, how am I doing with my time? I'm good, right? You're muted.
Yeah, I said we're very good with the time, and just wanted to find out if there's any questions. I know this is probably new for most folks. I don't know if anybody has ever. Is anyone here who has tried to make a temp before? I mean, most people are learning to place implants the first time, so I think this would be a very good reference material. Can we use, there's a question here that says, can we use custom abutment in single implant immediate case?
Can we use?
Like, yeah, placing the implant, the question, well, the question says, can we use a custom abutment in an immediate implant case?
Well, I guess your custom abutment, by virtue of a custom abutment, you can customize it by the lab, right? They most of the time either cast it or mill it, right? So for an immediate implant case, I find that you can plan it, and you can plan and have a custom abutment made in advance. But I think that's, the lab will try to do that because the lab will make money off that. But logistically, I feel that I'm wasting money if it didn't go all smoothly. There's a lot of things on my end that I feel like, okay, so if the implant is in place, because of whatever reason I can't get primary stability, and you have this custom abutment that is not used, and maybe you can reuse it at the time of uncovering. Okay, so I guess you can, but most of the time we provisionalize it at the time because we can customize it chair side, right? So the fact that if you're going to plan a custom abutment for a single immediate implant case, if you ask the lab to do it for you, yeah, they'll do it. They'll just charge you for it. But that's extra labor because you're customizing it, right? So I guess the short answer is yes, but why would you do it unless you have a lot of money to waste?
All right. Anyway, I mean, thank you so much. This has been, I'm telling you, this is one of the most valuable lectures in the series that we've had. We've been doing this for many months. So yours is very practical. You can watch it and do it, and you can, I mean, so many things to learn. There's so many terminologies in terms of materials and all that, in terms of the things we have available. But hopefully, we are going to hold on to this for a long time. There is a question here. It says, can an immediate implant protocol be ideal for patients with uncontrolled systemic disease?
Yeah, no, I wouldn't.
I mean, implant itself.
Implants itself for uncontrolled systemic disease shouldn't be. The patient should have control disease first. Like I find if you have a diabetic who's not controlled, wound healing is going to be compromised, even if you do everything ideal. And if the patient factor is not working for you, then the outcome will be less ideal, right? Not as predictable. So it's not indicated for uncontrolled systemic disease.
Okay. All right. Thank you so much, Dr. Leung. And hopefully, so this class, the group of participants, this is their last week. They've been on this for 8 weeks. And I believe, I know, I guess they will agree, they've learned a lot, and the videos are always there for them to go back to. And obviously, we also have some materials online. But thank you so much for giving us this this part of your weekend. We truly appreciate your sacrifice.
Well, thank you for the opportunity. I hope everyone will find something useful from today's presentation and last week's presentation. As you see, I try to be practical. And I think, yeah, but thank you for the opportunity. Anyway,
so Dr. Leung is very active on Instagram, and you can, Dr. Did you have your Instagram? I know from the first lecture you had like,
oh yeah, I have, let me see. My Instagram account is Beatrice Leung Prosto. So you can search me. You'll find my Instagram account. I do share my cases with various posts and videos just to help, share and disseminate knowledges around the world. So you're welcome to follow me. I have a blog on my website as well. They're all not always the same. And so, but yeah, I don't just talk about implants. I talk about natural teeth. I talk about dentures. I talk about whatever I see when my students or my colleagues are struggling. So those are my inspiration. So yeah, and if you have any question, you can reach out to me as well.
This is the Instagram page. So you guys, you want to follow on Instagram. I've been a follower of Dr. Leung for many years before I even got to know her. So it's just interesting that we're here today talking about this. And hopefully, I think, at some point in time, once we discuss it properly, Dr. Leung is going to be in Lagos, Nigeria. She's going to be in Nigeria doing this hands-on session. It's coming very soon. We're going to work out the logistics, visas, all the things, transportation, stipends. We are getting you to Nigeria, and that's going to happen. Believe me. Yeah, if you are willing to travel,
thank you.
Yeah,
I've never been to Nigeria. I've never been to Africa. So
you would come back with some native attire, which you'll come back with some pounded yam and some egusi soup. And in Nigeria is a fun place, fun people, and it will be. So let's work on that. Hopefully, in the next couple months, I'm working on an expo, a dental implant expo in Lagos, Nigeria, where we want to demonstrate some of these things that you've talked about. Especially, this is going to be part of the class. Everybody's going to do a temporary crown on an implant they placed on a cast. So in terms of using the suck down and the materials, so I would reach out to you more so that we can talk about it. Thank you so much for giving us.
No problem.
All right.
All right. You have a great weekend, the rest of it. Okay. Take care.
Okay then. Bye-bye.
Bye.
All right. We